in a professor of orthopedic physiotherapy and outcomes assessment, the current head of the Department of Physiotherapy of the College of Medicine, the University of Ibadan. She is a product also of the Oba Awon University, the Obafemi Awolowo University, formerly known as the University of Ife, in a graduate of 1989, and she proceeded even to do a master's and PhD in orthopedic physiotherapy in the University of Ibadan. Today we have Professor Adeshola C. Odole, BMR PT, MSc PhD, and she is going to be talking on the topic physical and psychological management of pain. She is one of the participants at just concluded African Pain Camp, and she brings along with her a wealth of experience arising from our participation even at the pain camp. We have the pleasure of having her expose us to several ways by which we can manage pain using physical and psychological means. Join me in welcoming Professor Adeshola C. Odole, who incidentally is my own head of department. But for now, she is a presenter, so I am a moderator. Professor Adeshola Odole, you're welcome.
Thank you. Thank you so much, Dr. Dada. Let me just share my screen. Please, can you hear me very well? I want to be sure that you can hear me. Can you hear me?
We can hear you. We can hear you.
Because as soon as I start sharing my screen, I won't be able to alter anything in terms of the icons. So I'll just share my screen straight away. Can you see my screen? Can you see my screen?
Not yet.
Okay.
Okay, now. Yes.
Okay. You can see my screen now. So I'm going to change to the... Please, can you see my screen?
Yes, ma'am.
Yes, and in the presentation mode. Yes,
we can see your screen.
Okay. So we are good to go. Thank you. So once again, I want to say a very good evening to all my senior colleagues, junior colleagues. And when I talk about colleagues, I do not mean physiotherapy colleagues. I'm talking about colleagues who are pain managers, so to speak. Pain managers not in the administrative level, individuals who have, in one way or the other, managed a patient who has had an experience of pain. So my name is Adeshola C. Odole. I am actually very honored and privileged to be making this presentation this evening. When I was contacted to make this presentation, the suggested title was Non-Pharmacological Management of Pain. And I know that for some of us, including the presenter of today, we are so used to classifying treatment approaches in pain management under these broad classifications of non-pharmacological and pharmacological management. In fact, when I went through the literature review for my students, I always look out for these two broad classifications. But now I know better. I'm following my attendance at the first African Pain Camp. I know that it is not appropriate, it is no longer appropriate for us to classify treatment approaches in pain management under those two classifications. So by the time I'm done with this presentation, I hope you will get to understand what the 3 Ps of pain management, what these entail. So before I go on, I want to extend my deep appreciation to the International Association for the Study of Pain for the part sponsorship to attend this pain camp in Kenya. Basically, what I'll be doing today, I'll be reflecting on the knowledge gained during the pain camp. I also want to deeply appreciate the leaders of the Society for the Study of Pain in Nigeria for their wonderful support during the selection process for the pain camp. The pain camp took place from 23rd February to 25th February 2025 in a very, very serene environment. Sincerely speaking, when I say serene, I mean serene, at the Loreto Mary Ward Center, Laganta, Nairobi, Kenya. I'm sure by the time you get to interact with anybody that attended that camp, you'll get more information on how serene and how that environment is more than adequate for a camp. By the time you look at the individuals in blue t-shirts, these individuals are the facilitators and all the campers. We all had a day that we all wore our t-shirts. And incidentally, a few minutes before the start of this program, I had to call our president, Professor Bamidele Owoyele, and I needed a piece of information from him. And what he has on his DP is him putting on the t-shirts. And I was actually very excited when I saw that on his DP. By the left-hand side of the screen, you will see the powerful 7 people, the Nigerian delegation, the powerful individuals that represented Nigeria at the pain camp. These individuals are our president, of course, Professor Babidele Oyele, the immediate past president of SSPN, Professor Adewonke Akipelu, and Professor Lizzie Nwaso, one of the esteemed ambassadors of SSPN in the IASP. These 3 people were part of the facilitators, while the remaining 4 people that are a physiotherapist in terms of discipline. Now we have a physiotherapist as one of the campers. We have an anesthetist as one of the campers. We have a surgeon as one of the campers. And we also had the dietitian as one of the campers. I think it is important that I start this presentation because it's basically, the presentation is basically maybe somewhat reflections of what happened at the camp. So I am not here to teach. Who am I to teach esteemed colleagues who have been managing pain for quite a while? So the major objective of my presentation today is to present an overview of the physical and psychological management of pain following my attendance at the first IASP African Pain Camp in Kenya. But specifically, I have some specific objective, which is to review the burden and classifications of pain. I hope that I will be able to challenge us to appropriately manage our patients using the RAT principle. The RAT is not the pest that we see in our houses. It's a principle, it's an acronym. I also want to emphasize the need to manage our patients appropriately using the physical and psychological management. And I hope that at the end of this presentation, I would have laid emphasis on the concept of chronic pain as a disease and the need for an interdisciplinary approach. So basically the outline, talk a little bit about the global burden of pain, classification of pain, chronic pain as a disease, chronic pain as a whole person experience, the RAT principle, modes of pain treatment, types of pain treatment, the 3 Ps, physical and psychological treatment of pain under the 3 Ps. And I would have, we have just one case scenario that I would want us to to look at. And I would end with talking about health for all. But before we go on, please, I want to crave your indulgence, please. Has anyone ever experienced pain? Has anybody in this meeting this evening, have you ever experienced pain?
Yes.
Please, I would want you to briefly do something for me. I would have wanted to do a poll, but I was just looking at the time constraints of having to put a poll because I don't know if I'll be able to cover all that is needed to be covered because this topic is actually a very wide one within the next 35 to 40 minutes. So please, I want to beg of you, we have 35 people on this Zoom meeting. Please, if you have ever experienced pain, please just write it down, yes, and indicate the parts of the body. For instance, for me, about 3 weeks ago, I had this severe toothache. Very, very severe toothache. In fact, I can even call it orofacial because I was having pain at one part of my face. So please, I would want you to do that, please, in the next few seconds. Dr. Dada, please, you would help me to read it out because I can't even read anything out now with this screen. Please help me to look at the charts and try, and we have 36 people. Please, I beg of you, please, let's make this very interesting. Let's make it interesting. We have 36 people and only 9 people have responded. Can we have more people respond? If you have ever experienced pain, please. We have 13, 16. I beg of you, please, want more responses? Want more responses? These individuals, I don't know who the person is.
I don't know.
Are you please mute or can the host, any of the co-hosts, please?
No.
This person. 25 people. Can we make it to 30? Dr. Dada, are you making the counts for me? Can we have 30 people? 26, 27? $27 people out of 37. Okay. Dr. Dada, can you please just give me a summary? We have 29 now. How many yeses, how many no's?
Well, I can, summary will be difficult a bit, but I have seen that well, all parts of the body covered: right hip, low back, elbow, back pain, acute abdomen, on the hand, toothache and back pain, low back, left knee, back pain, lumbosacral pain, tooth pain, SIJ shoulder, sole of the foot, right knees and shoulder, leg, knee pain, upper back pain, leg pain, labor pains, neck, scrotum, headache, yes. Okay, I mean, low back.
Thank
Almost
you so much. Thank you, Dr. Dada. Thank you so much. So if you look at having 32 people respond out of a total of 39 people on this Zoom meeting, that speaks, you know, a lot. And it tells me that if we are to carry out a kind of prevalence study, with those of us in this call right away, would have a prevalence rate of close to 90% of individuals who have suffered one kind of pain before at different, one or more than one regions of the body. And this tells us again that pain is the occurrence of pain is actually a burden. It's something that is concerning. Globally, it has been reported that pain affects over 1.5 billion people worldwide. And then it is the leading cause of disability too. You know, when we talk about when an individual has an impairment, whether it is impairment, whether it is activity limitation, whether it is participation restriction, all of these come under the umbrella of disability. So if you have ever experienced one pain or the other, it could lead to you being disabled. Not just physical disability, we know that pain can affect so many components of the body. And 60% of all disability adjusted life years, the dailies, which is a sum of the years live with disability, illness, or injury with the years of life lost is something that pain has a high prevalence on. Low back pain is the leading cause. If you look at what we have just done, I'm sure if we do the proportion of the weights, we'll find out that low back pain is actually higher. You know, many of us on this call would have experienced low back pain, and it is the leading cause of years lived with disability. The economic burden of pain cannot be overemphasized. Globally, about $638 billion annually in healthcare costs and lost productivity. Permit me to just talk about a research that I did with some other colleagues on the economic burden of low back pain, on patients seen at the outpatient physiotherapy clinics of secondary and tertiary health institutions in Ibadan. And that was a study that we carried out over 10 years ago, over almost 15 years ago. And we found out that the annual economic cost of care of low back pain was about 140,000 naira, you know, summing up both direct and indirect costs. And there was an average loss of work hours per visit, about 10.25 plus or minus 6.75 hours of lost productivity per visit. Unfortunately, again, pain disproportionately affects vulnerable populations, of which low and medium income countries belong. The prevalence in these countries is at least as high as what we have in the high income countries. But unfortunately, as we all know, there are fewer resources for management. And I think that actually resonates with the IASP 2025 year theme: pain management, research, and education in low and middle income countries. I have said that I'm not here to teach. It is like an overview. It is like a reflection just to guide us and remind us of some of the things that we know. So in the classification of pain, we classify pain under temporal, talking about the duration. We classify pain under mechanistic, which talks about the mechanism, and we also look at the cause of pain. Of course, I cannot begin to tell us here about what acute pain, chronic pain, and all of this stuff is all about. And basically, all of these classifications can be summed up, or the classification can be done by simply asking 3 questions. How long has the patient had pain? That will help us to know it in terms of duration. What is the cause of the pain? And that will help us to know it in terms of the cause, even though I'll be putting emphasis on the ICD-11 classification. What is the pain mechanism? You know, we're asking about how the signals are generated and how these signals are processed. So if you're able to ask these 3 questions, you'll be able to classify pain under duration, mechanism, and cause. Let me briefly just talk about the mechanism. Nociceptive, when we talk about somatic pain, visceral pain; neuropathic, central, when we talk about alteration in the somatosensory nervous system; the nociplastic, altered nociception despite no evidence of tissue damage. Then the cause, using the ICD-11, we have chronic primary pain, and we have 6 subtypes under chronic secondary pain: cancer-related pain, post-surgical or post-traumatic pain, neuropathic pain, secondary headache or orofacial pain. You know, I told you that I had orofacial pain or toothache about 3 months ago. Visceral pain too. Then secondary musculoskeletal pain. Excuse me. So these are the major classifications. In times past, we've often talked about psychogenic. We've often talked about the nociplastic is not something that we often refer to, but now it has been found out that the psychogenic can actually come under the nociplastic kind of type of classification. So the nociceptive pain usually is associated with tissue injury. For instance, if somebody had just had a fracture, so pain secondary to a fracture, pardon me, I'm a musculoskeletal physician, so I'll be making reference to musculoskeletal condition. Okay, let me say, if somebody has just had a surgical incision, for instance, it is a kind of pain that is associated with tissue injury. That is nociceptive. And the one for neuropathic, like I said, when there's an abnormality of the nervous system, when there's a lesion or disease of the somatosensory nervous system. So I would not want to talk so much about that. So I want us to if we were to be having a physical meeting, honestly, we would all have carried out this ice block experiment. That was one thing that we all did in the camp. We were told to hold on to an ice cube and to hold on to it for as long as we could tolerate it. And after that, we should now describe the pain that we all felt. And it was not something funny for me. I couldn't hold it for up to 1 minute. I was only able to hold it for less than 1 minute because I just had this excruciating pain, and it was really, really, really very painful. It's about my nociception, and it's also about my pain perception. I don't know. So at the end of the day, we had people describing their pain, the pain experience using different descriptors, excruciating, burning, very severe, different descriptors. And that also confirms the fact that pain in itself is very subjective and it varies between individuals. We all know the definition as given by the IASP, that pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. With this ice block experiment, I would want you to do it when you get home. If you have a family of more than one or more than two rather, just try it. Ask members of your family to hold on to an ice cube and ask for their pain experience. So pain is a personal, sensory, and emotional experience that can affect the individual. Any individual that experiences pain would translate it to the family and to the society at large. So basically, context actually influences pain perception. I've watched videos on Nollywood where they would ask a man that if you want to marry a lady, you have to go through these beatings, and you will find the man just not expressing pain, so to speak, and just, because of what the man wants, the beautiful lady that the man is looking up to having. So context sometimes, if you have to go through a prick, or you have to have an injection, and you have somebody patting your back, or somebody saying sweet nothings to your ear, it could influence your pain perception. So pain is not necessarily equal to tissue damage. The ice block experience that we did, I had so much pain and I didn't have any tissue damage. So that also confirms the multi-dimensional nature of pain. Please permit me, going through the different classifications of pain, I would really want to talk about chronic non-cancer pain, because there are so many things about management of pain in terms of physical and psychological management. And this 40 minutes presentation cannot touch everything. So I just want to limit it to chronic non-cancer pain. We have often regarded pain as a symptom. But now when you talk about chronic primary pain, it is not just a symptom. It is a signal of tissue damage. So chronic primary pain is now being regarded as a disease. So we treat chronic pain as a disease, as a health condition in its entirety. It has been recognized in the ICD-11 as a health condition in its own right. And because it involves maladaptive neuroplastic changes, when you talk about when the process where the brain just changes in response to repeated exposure to an experience that is either stressful or traumatic. We have often joked about neuroplasticity in my department. When we talk about neuroplasticity, we just call on those in neurology. Oh yeah, you are the neuroplasticity individuals. But now we know that it is not just about neurology. It is something that occurs even in musculoskeletal conditions, even in any form of chronic primary pain, when the brain's ability, now changes and adapts due to experience. And we know that in chronic pain is a long-term thing. So the exposure okay, the exposure of the individual to pain is very concerning. It's a significant public health concern. I had said earlier that the prevalence is almost at least as high as that in high income countries. So because of this, treatment must be comprehensive and it must address multiple dimensions. We've been talking about multidisciplinary approach to pain management, multimodal, but these are not just sufficient. We should continue to talk about interdisciplinary approach that covers every aspect, every component of pain experience, whether it be biological, psychological, or social. And if we must engage in this interdisciplinary approach, the patient's voice is very, very important. Gone are the days where we just think that it's just all about us. We are so much in a haste to assess our patients that present with pain. The voice of the patient is crucial if we must have successful treatment outcomes. So let's go to the RAT principle. I'm sure you can see the picture of the rat there. That's the rat there. And then the RAT principle is just about we assessing pain. So when we are assessing pain as a health condition, we should assess properly. It's not just enough for us to just include pain intensity alone, which I am very, very guilty of. What I concentrate on most time is just to assess for the intensity of the pain. But now we have to use this RAT approach to assess our patients. What does this mean? The R means recognize. In recognizing the presence of pain in our clients, it is not sufficient for us to just look. It is not sufficient for us to look when we want to assess pain in our patients. The best way to identify pain, the best way to recognize pain is to ask. That is, if possible. We know that sometimes when we have unconscious patients, we may not be able to ask. But if we are able to ask, please, we need to ask and look. That is the R aspect of the RAT approach in pain management. Then again, we talk about assess. A is the assessment. We have to assess our patients, not just about the severity and the intensity alone, which we are so used to doing, using different outcome measures, using different pain outcome measures. These are not just sufficient. We should also look at the type of pain. We should always assess our patients under this heading when we talk about the type. Is it acute? Is it chronic? Is it cancer? Is it not cancer? Is it nociceptive? Is it neuropathic? Is it nociplastic? When we are documenting all of these three components should be under the assessment of pain. And the last thing that we don't often look at when we are assessing pain are the other factors. The other factors are equally as important as assessing intensity, as knowing the type of pain, as knowing the duration, the cause, and the mechanism. The other factors like social and psychological, very important. And then in the ICD-11, there are three key dimensions. You know, I said that I'm very guilty of assessing only pain intensity. We should also assess pain-related distress. We should assess pain-related interference in activities. You know, we assess these three key dimensions when we are managing our patients. And when we are assessing for other factors, social, psychological, we should use appropriate outcome measures in the assessment. So the last letter in the RAT approach is the treatment. I deliberately left the non-pharmacological and pharmacological because I know that some of us are so used to it, but it is no longer non-pharmacological. I will still talk about it, but I'm just waiting. When I get to the slide of reference, we'll talk about it. So in the treatment of our patients, especially those that have chronic primary pain, multimodal is okay. But we are not just saying it is multimodal alone. Multidisciplinary is okay. But if we must address the biological, psychological, and social factors, we must do an interdisciplinary pain management approach. We should not just focus on pain relief. That is what we often do. After assessing their pain intensity, we think that, oh, patient's pain has reduced from 5 to 2 using the NRS, or it has reduced from 7.2. It has reduced from 7.2 to 1.4 using the visual analog scale. And having done all of this, please, having done the recognition, the assessment, and the treatment, we can still go back to reassess our pain, the patient's pain again, and go through the process again. We should not forget to use relevant patient-reported outcome measures. I put this here to stimulate us. For those of us that have not done the Essential Pain Management online course, I did it. That course is very detailed and comprehensive, and it is free. I want to encourage every member of SSPN, and even those that are on this call that are not SSPN members, but who I believe will join us in SSPN, please just go on the internet, type www.essentialpainmanagement.org. You will get to see this online course, the things that you need to know, so many things that we need to know when it comes to pain management. So from the previous slides, I'm sure you agree with me that pain experience is more than nociception. It's more than the signals that move from the periphery. It's more than the transmission of the nerve impulses or the neural impulse from the periphery up to the brain. It is not just about that. Pain experience and pain perception.
They don't do body for example. Not coming to
there
do.
are so many interacting factors. I'm not going to all of this, but just to mention that we know that the biological, when we talk about tissue damage, psychological, when we talk about so many things, depression, anxiety, social, isolation, and all of that. I love the Lusser's model of 1982 that talks about nociception, pain, suffering, and pain behavior, and the fact that social context can influence all levels, and this has significant implication for assessment and treatment. Yes, this slide is just to reiterate what I've been talking about in terms of nociception and pain, and the fact that we have so many things, interacting factors. Our beliefs can influence our pain perception, our mood, our cultural factors, social factors, pain experiences, other illnesses. So when we are assessing our patients that present with pain, we should not forget that in recognizing, asking and looking, in assessment, basically, that is why it is in purple. We should look at all of these interactive factors that would help us in managing our patients. So that was, yes, this is actually very interesting to me. During the camp, I learned about case formulation. If I'm to look at it literally, when we talk about English, I will just say, oh, case formulation. I want to formulate a case. So I want to find out what the diagnosis of the client is, or what the diagnosis of the patient is. It is not about making a diagnosis. It is not just about making a diagnosis. In case formulation, which we are all supposed to do in an interdisciplinary team approach, we should develop a comprehensive understanding. We should, when we clock our patients, all of the contributing factors, all of the factors that contribute to the pain experience, we understand it, we identify them, we look at the ones that can be modified. And in doing this, our patient is important too. So our patient is very, very important. And when we do this, when we look at, does this patient have physical factors? Do we have psychological factors? Do we have social factors? Our treatment plan will now be matched to the individual patient or case that we want to treat. So this is how a case formulation looks like. I'm looking forward again to a time where maybe we'll be able to organize a kind of an in-person workshop where we'll be able to challenge ourselves, have clinical case scenarios, and formulate cases. If we look at this particular one, we talk about chronic pain. So we look at what are the secondary stage changes in the nervous, immune, endocrine system. Does this patient have triggering factors? Do we have input from context with their family, healthcare providers, from the medical history? We look at all of that. Oh, sorry, I'm not done yet. What are the behavioral changes, unhelpful beliefs, the health-seeking behavior of the patient, or the patient feels that he has stepped on, or she has stepped on something. That is why she's experiencing this radiating pain. Or maybe the patient has undergone many repeated treatment failures. Oh, if this patient is a case of cancer, is this patient opioid dependent? You know, you look at all of these interacting factors. Is there any physical deterioration in terms of strength, fitness, joint stiffness? Does this patient have psychological responses? And does this patient have excessive suffering and disability? We'll look at all of this and we'll put them together. If you look at this, no single healthcare professional can manage this. No single person. It involves interdisciplinary pain management. So in interdisciplinary pain management, like I said earlier, it is not just about multiple interventions within one discipline, one particular discipline, and using different kinds of interventions. It is not just about that. And it is not just about multidisciplinary, when we have multiple disciplines working separately. That is what we often do, to the best of my own knowledge. At the University College Hospital, we often engage in multidisciplinary approach. And that brings me to share an experience I had several years ago. I think it's almost 10 years ago. I was on a social visit to see a friend's mother who had just undergone hip arthroplasty. So when I got to her bed and I was just asking her, Mama, I visited the mama then 2 weeks after the surgery. And I was just asking her, Mama, you are still lying on the bed. Are you not sitting up? Have you been referred for physiotherapy? You know, I wanted her to sit up, get out of bed. And Mama said no, that she was told to buy a Zimmer frame. And sincerely speaking, it was appalling to me. That why would a healthcare professional ask the patients to just get a Zimmer frame and teach himself or herself how to move with the Zimmer frame? Coincidentally, on that same ward, I saw an orthopedic surgeon on the ward. And I approached the orthopedic surgeon and I asked him that, oh, please, I'm thinking that Mama should be referred for physiotherapy so that we can get her ambulance as early as possible. Because I know that for somebody that has undergone hip arthroplasty 2 weeks ago, the Mama should be moving by now. The Mama should not be allowed to just lie on the bed, so that we will not just have some other secondary complications. And the response I got from the orthopedic surgeon is something that I do not always like to talk about. The orthopedic surgeon told me on the ward that he has had an experience with a physiotherapist, that physiotherapist mismanaged his patient. He was so emphatic about the use of the word "my patient." And now I cannot allow any physiotherapist to mismanage my patient again. Well, I had to tell him that it's not about your patient. Nobody owns a patient. It's about we doing the best for the patient. It's about looking at the person that is the most important stakeholder. That if this thing is going to benefit the patient, the fact that you have had experiences or whatever with a physiotherapist does not mean that this patient must not be given the total care, the care that the patient deserves. And he didn't like it, but I had to tell him. This is not to say that this is what obtains, you know, generally. It is just an experience that I had several years ago. And even when patients are referred to other disciplines, when they are referred to other disciplines, they work in silos. We do not come together to manage our patients in an integrated approach, which is the real interdisciplinary approach. Multimodal treatment being provided by a multidisciplinary team in a collaborative atmosphere. We collaborate together when we are assessing the patients using that RAT principle when we are treating. And we have this shared biopsychosocial model and goals that align with the patient's goals. And when we do this, how many of us have had this experience too, that when we have a referral for, let me speak about my own profession. I know that I've done it in transfers, which is not really the best. When we see a referral and we just look at the referral, How can an orthopedic surgeon just refer a patient like this? And right in the presence of the patient, we are saying, why does this person have to do this? That is not good. It's not good enough. In an interdisciplinary approach, we are speaking the same message to the patient, regardless of anything, because we have all looked at this patient's condition, collaborating together, integrating all of those factors together, formulating the case for the patient. Then we are able to speak the same message, and there will be no conflict in management. So that is what the interdisciplinary pain management is all about. So there is no way we are going to manage our patients using the physical and psychological pain management approaches without talking about interdisciplinary pain management. That leads me to the types of pain treatment, the 3 Ps. So we have the physical, we have the psychological, and we have the pharmacological management of pain. These are the 3 basic umbrellas. In some instances, we may need to manage our patients with surgery. Somebody having a disc herniation, so surgical intervention too is very, very important when we are managing or treating our patients that have pain experiences. Under physical, I've just listed a few. There are so many things. And I hope that someday again, we would have to have presentations that will focus on each of these treatment approaches. We use exercise therapy, different kinds of exercise modalities, manual therapy, mobilization, physical modalities, using TENS, our shortwave data, using so many things that we use, ultrasound in managing our patients, acupuncture. For the psychological, I'm not a psychologist, so I don't think I'll be able to speak in details. But based on what we learned at the camp, cognitive behavioral therapy, mindfulness-based interventions, reassurance, self-management strategies. This is the cocoa, this is the flesh of management, when we empower our patients. And empowered patients would always help us to reach the goals that we have set on time. I'm not into pharmacological treatment management, but I know that non-opioid analgesic adjuvants and all of this stuff, even though they have limited role for chronic non-cancer pain. So under the self-management strategies, diets. If I do not talk about diets, I don't know if our anesthetist, our nutritionist is on this call. She kept talking about it, referring us back to diets at the camp, that we still need to talk about diet. There are instances when we have to, that good nutrition will be the major thing that we have to give our clients. Sleep, physical activity, very, very important in the management of pain. Gone are the days when people talk about the fact that when you are in so much pain, you should not do anything. Just go and lie down. That is a myth. That is a myth that should be discarded. So this brings me again to the ICF. There is no way we will talk about non-pharmacological management of pain, and I mean physical, psychological. I hope I will get used to not talking about non-pharmacological, because that was what we learned at the camp. There is nothing like non-pharmacological management of pain. The ICF, the International Classification of Functioning, Health, and Disability, is an important classification system. So if we are saying that chronic primary pain is a health condition, so that means where we have a health condition, we will now have our, where we have this, so we are going to replace this with our chronic primary pain, which is not just a symptom, which is now a health condition. So we are now looking at the impacts of this health condition on the functioning across the body functions and structure, across the individual level, and across the societal level. When we have problems and alterations in the body functions and structure, when we have such as significant deviation or loss, we talk about impairments, okay? And in activity basically is the execution of a task or action by an individual. So when there are difficulties encountered by an individual, don't forget we are still talking about our health condition, chronic pain. So if this chronic pain causes difficulty in executing a task at the individual level, we begin to talk about activity limitation. Okay, because the impairment, activity limitation, participation restriction are the negative impact of the health condition on the individual. And I remember I said earlier on that when an individual has pain, it will affect the individual, and it could even affect the society at large. And for all of these components, well, participation is just involvement in life situation. So when an individual also has problems or experiences problems in his or her involvement in life situation, there's participation restriction. So disability covers all these three. You know, disability covers impairment, covers activity limitation, and covers participation restriction, you know, the negative aspect of the interaction. So this interaction between a person's health condition, that is chronic pain, chronic primary pain, and the individual's contextual factors. We should not forget this. You know, I said context can actually influence pain perception. These contextual factors, that is environmental factors and personal factors, are very important. When the individual is moody, when the individual has anxiety. So there's no way we are going to have an interdisciplinary pain approach without using this ICF classification. I use it a lot, not for chronic pain, because I just learned about chronic primary pain as a health condition at the camp. But basically, when I'm managing my patients, with fracture, patients with low back pain, patients with osteoarthritis, I normally break them down, you know, into impairments, activity limitation, participation restriction. Okay, and of course, these contextual factors can either be facilitators or barriers in your management of the patient. So if there are barriers, we need to work on them. We need to also focus on them, because if I am to talk about all of this thing in just a very simple format, I would say that it is any condition that makes it more difficult for the person. When we talk about is any condition of the body or mind that makes it, condition of the body or the mind, that could be the impairment, that makes it more difficult for the person with the condition, that is chronic pain, to do certain activities, that is activity limitation, and interact with the world around them, that is participation, relative to the environmental and personal factors. So, physical approaches, I think I've talked about that. Basically, there are so many things about physiotherapy when we talk about physical approach. So it's based on the clinical reasoning of the physiotherapist to make clinical decisions or to make judgments on the most appropriate tool or modality that he has evidence to support it. So there are so many approaches that we use in physiotherapy, like I said earlier on. So I might not be able to delve into the specifics, because I believe that the specifics should also cover a presentation on its own. Diet, I've talked about it. Supportive devices, getting something as simple as getting a brace or using a cane, or using a Zimmer frame can help to alleviate the patient's pain experience, and acupuncture. For the psychological approaches, I mentioned earlier the cognitive behavioral therapy, which are the acceptance and commitment therapy. All of these interventions, mindfulness-based interventions, all of these interventions have been proven to have evidence, okay, across multiple pain conditions. I'm looking at my time. I have to move fast now. The self-management strategies, you know, when I was talking about physical activity, we should always encourage our patients, regardless of the intensity or severity of pain. Activity must be encouraged. We can pace the activity. You know, we can pace the activity to avoid boom bust cycles, you know, when you just have large cycles of activity. So you can gradually increase the activity level. And when we are increasing the activity level, it must be time-based. It is not supposed to be pain-based. It is not supposed to be pain intensity-based decision. It is something that should be time-based. Education, education, education. An informed person is very much involved in his or her management. So education about pain neuroscience, for the healthcare provider, for the patient, you know, so that For the patients, we need to address misconceptions about pain so that then again, we can set realistic expectations with our patients. I think I've mentioned that when I was talking about setting goals. Lifestyle modifications, sleep hygiene, stress management, diet and nutrition. For emphasis again, talking about diet and nutrition, the regular physical activity. So let's quickly look at this case scenario that I want us to quickly do in the next few minutes. And we have this case of an individual that has a chronic low back pain. Please pardon me that I chose chronic low back pain because that is what I manage most times. A 50-year-old man that presented with long-standing low back pain. Long-standing low back pain. His pain began more than 20 years earlier with a lumbar disc herniation. Please, you can begin to take some of the points down because we are going to do an assessment of this patient, even though it's a virtual thing. I wished we have a physical or in-person meeting right now, but let's just make do with what we have. This patient had lumbar discectomy 15 years ago and was pain-free for 2 years after surgery. He described his back pain as a constant severe dull ache, sometimes throbbing and sometimes radiating to both legs. The patient had undergone numerous treatments, acupuncture, physiotherapy, including pharmacologic therapy, okay, but nothing relieved the pain. He remained significantly disabled. He had impairments. He had activity limitations. He had participation restriction and with the ongoing pain. And he expressed his frustration with his pain. He was even saying that he was ready to give up and wanted to discontinue all forms of treatment. On physical examination, stable vital signs, pain intensity was 10/10. The patient was very alert, coherent, but irritable. He kept shifting position while seated. He had mild paravertebral tenderness and muscle spasm. Pain over the back of the thigh on straight leg raise was 60 degrees, decreased motor strength 4/5. Sensation was intact on both lower limbs. This case scenario was one of the ones that we dealt with, that we discussed during the pain camp. So it is not a case scenario that I imagined or got by myself. So now, the questions I'm going to ask us, using that RAT evaluation, okay, how are we going to recognize pain in this individual? How are we going to recognize pain in this individual? Can somebody, one person, please, using that RAT evaluation, we are supposed to say recognize, and in recognizing, we're supposed to ask, and look, but we do not have the patient with us now because it's a virtual meeting. So we cannot talk about look. So the asking, we look at the information that the patient has provided to be able to get the R to talk about the recognizing, but we can skip the recognition aspects of the RAT principle because of these virtual components of the meeting. So let's go to assessment. I need one person to just bring out one or two things in terms of assessment based on the RAT approach that I talked about earlier. Just one person. Dr. Dada, please, just one person because of our time. Can you unmute anybody that wants to try this assessment? Do we have anybody that wants to just talk about it in terms of the intensity, in terms of the type? Dr. Dada, are you here? Can you all hear me? I hope I'm not
Yes,
speaking
ma'am.
to...
We can hear you.
Okay, who just talked now?
Yes, we can. We're waiting for somebody to raise their hand.
Okay, nobody, please raise your hand now so that we can finish this thing on time and wrap up, so that we'll allow time for questions and answers. Do we have anybody? Nobody. Okay, maybe I will just pick somebody. Anybody, I will pick anybody. It's better we volunteer, but since there's nobody that is volunteering, okay, I'm going to pick anybody. Anybody. Can Dr. Dada, can you unmute Bolanle Akogun? Can you unmute Bolanle Akogun?
I've sent the request.
Okay. Can we have Dr. Daramola?
There's a response in the chat box, though.
Okay, can we have Dr. Jonathan? I can see that she's.
I just came in now.
Okay, I saw that you were muted, so I just decided that.
I'm so sorry.
There's a chat.
Okay, there's a chat. Okay, please read it out for us, please. Let's look at that briefly. The assessments, the intensity. Let's talk about that. What type of pain is this? Is it cancer or non-cancer pain? Is it acute or chronic? What is the mechanism? Then we can talk about the treatment. Can you read it out,
Okay,
please?
from the chat. Chronic
Yes.
nociceptive low back pain with
What
severe activity limitation.
Okay, what about the mechanism? You know, you have to talk about those three components, the mechanism. And you should not forget the components in terms of assessing for their pain, as it's pain related, as it affects their stress and interferes with their activity. All of these are important when we are assessing our patients. So because of time now, treatments, what kind of treatments based on what we already saw? Let me go back to that. Let's go back to, so that we'll look at that information again. The patient is already giving up. He has had different kind of treatments. So what are we going to advise? What in treatment approach would we advise for these patients? Dr. How many minutes do I still have more?
None.
None. Hey, so I'm rounding up. So these points, we can discuss that later on, talking about what other information were not included in the case scenario. Please let me just go on. Constructing case formulation. I wrote all of these in terms of the case formulation. Maybe I should just look at the case formulation. You know, the chronic pain, failed back surgery syndrome, repeated treatment failures, unhelpful beliefs and thoughts, behavioral changes, significant psychosocial factors, excessive suffering and disability. There's no way we are going to manage these patients with, you know, with only physical approaches or with only pharmacological approach. Psychological approach is very, very important. So the treatment of the patient should involve a comprehensive interdisciplinary approach, focusing on function rather than pain elimination. CBT, self-management strategies, diet, having realistic functional goals, and then reassurance. So there are so many challenges in implementing interdisciplinary pain management, just a few of them. Classified under healthcare system barriers in our context, lack of reimbursement models, limited resources, bias towards biomedical approaches, knowledge barriers. We need to have more knowledge, pain education knowledge. Please go and enroll or do the EBM online course so that our knowledge would be widened and increased. Patient barriers. Sometimes patients want quick pain elimination, so they need to be educated. Sometimes our cultural beliefs that is particularly problematic in low and medium income countries. So the key to success in pain management is collaboration, team collaboration, patient-centered approach, individualized assessment, comprehensive assessment, case formulation, education for patients, families, and communities. I want us to know that access to pain relief is a human right. We cannot deny our patients this access to pain relief. We need to have a good understanding of all approaches, but I'm talking about physical and psychological approach this evening. It is an essential part of universal health coverage. So our physical and psychological approaches, it will reduce reliance on medication. I'm not saying that we should not focus on medication, but it will actually reduce reliance. We will not have case of over-dependence on medications. It will empower our patients. It's something that we can adapt to resource-limited settings. It will address multiple dimensions of pain and experience. I'm begging every one of us, at whichever level that we are in our small corners, let us be advocates for interdisciplinary pain management wherever we are. So the key takeaways now are Pain is a complex biopsychosocial experience, which we all know. Non-pharmacological approaches, and I'm talking about this now, maybe I should even remove that. I should rather say physical and psychological approaches are essential components of pain management with very strong evidence. Interdisciplinary approach is the gold standard, focusing on function and quality of pain, not just pain reduction. Pain education, patient education, active involvement are crucial. Access to comprehensive pain management is a human right. These are my references. I want to thank every single one of you for your attention, and I'm open to questions and answers. Thank you very much.
Thank you very much, ma'am. Thank you for the presentation. And thank you for taking us through your experience, at the same time exposing us to the current trends about pain management. We have the floor as it's open to everyone to make contributions, ask questions, and then seek clarifications. And if there is a need to correct too, it's allowed. Ladies and gentlemen, the floor is open. So while I wait for hands to be raised, I guess we can read some of the comments. Thank you for the beautiful lecture. Thank you, Prof, for the beautiful presentation. Thank you very much for your presentation. Excellent informative presentation. Thank you, ma. Please, are we going to have the lecture materials? That's a question from Khadijat Shuaib. If you are on our platform, most likely you can get access to that. And then we usually put out the YouTube YouTube format or version of the presentation. It will download the YouTube version and it will be shared. But you need to be on our platform for you to have access to it readily. But if you have anybody on the platform, maybe you can get in touch with them. Again, we can also use this opportunity to tell you that membership is open to all professionals. So, Professor Ikeaja, you went on Prof. Billion lecture. Dr. Ewu Mazino, Alexander Gordons, well done, ma. Lots of commendations.
Thank you very much. Thank you,
Detailed and
everyone.
insightful presentation, Dr. Kiwande. So questions?
Hello, Roa.
Any question, please? It's like there are no questions, Dr. Dada. Maybe the presentation was not well understood, and then people it's too simple, or maybe it is too simplistic or something. I want to enjoin us to please use the RAT approach, please. The RAT approach henceforth when we are managing our patients. And then let us spearhead this interdisciplinary approach wherever we are, please. We can do it. Nigeria can take the lead. And I hope SSPN would look into maybe having a kind of a workshop, an in-person workshop where we can delve and dig into all of these components, both pharmacological and have different case scenarios, cancer, non-cancer pain, scenarios that will fall under the classifications, whether chronic primary or chronic secondary, and the 6 subtypes. Thank you.
Our presenter, you said, well done. Everybody have been congratulating you for a job well done, even though you expected a question and then you haven't got a question. But you now said that we hope SSPN will organize this. And I want to ask you, who is SSPN? If you as an officer, as a member of the executive is now saying SSPN, so I think you are also in the best position to advocate for this. and to
I'm
help
sorry,
us.
my president. The thought leaders of SSPN will look into it and see the possibility of having an in-person kind of a workshop.
Yeah, I think that's good.
I've
But then,
reframed it, my president. I'm sorry.
okay. So the nutritionist is there and it's also greeting you, saying well done.
Thank you.
Let me ask a question. Who do you think would be in the best position to advise for these psychological and physical therapies in a joint hospital setting?
Okay, I would rather say that with this knowledge, anybody that has the first contact with the patient, it could be any one of us. It could be any one of us. If I have the first contact with the patient, and then we have pain clinics in our unit, even if we do not have pain clinics, we can initiate it. Okay, if I during my clacking using this VAT approach, we are supposed to look at the other factors. So by the time I use this VAT approach and I find out that there are other factors, psychological, social factors, I would refer to the appropriate healthcare provider, healthcare professional. Then we can decide to have meetings together, in a collaborative manner to manage our patients, not just referring. Now, we'll not say we have multidisciplinary. So anyone that has the first contact with the patient can initiate that. So.
And so the essence is multidisciplinary, and
interdisciplinary, sir.
Where there are no pain clinic, it should be encouraged, right? What do you want to say about pain clinic where there is none?
No, yes, sir. Well, my own philosophy in life is that no matter how long a journey is, somebody can always initiate it. Any healthcare provider in any health institution, whether tertiary, whether at the primary level, whatever, secondary, we can always initiate something. Even if we do not have pain clinics, we can initiate it. By the time we begin to have pockets of individuals discussing patients' cases, formulating cases. This group of individuals can be the advocates for the pain clinic. It is something that is doable when we know that this is about somebody's rights, human rights, and we should not deny our patients access to optimal care. So where there are no pain clinics, we can always initiate it. If for instance, if I'm working in a place where there are no pain clinics, and I know one Professor Woyele that can add something to the patient, I will go and meet him. I don't mind. Professor Woyele, I think this patient, I also think the dietitian will also do something. We go and meet her. We discuss. We now form a group of advocates for pain clinics. And our voices will be heard. Our voices will be heard somehow.
Sorry, I'm trying to mute this person before I continue. Thank you. I'm sure you are ready for questions. So you mentioned that the patient should be empowered with, or should learn to have pain neuroscience education and what have you done. And you emphasize the importance of education and how great it is. Well, what if the patient have the education and then the caregiver is not even prepared to let the person know what is the next line and what have you? There are certain times that even some patients don't even know what they are being diagnosed for, and they don't even have access to their record. What will you say to this?
It is unethical. It is actually unethical for we as healthcare professionals not to disclose information to our clients. Like I always say, though, I've always said it over and over again, it is a paradigm that we must shift from. We talk about healthcare professional dominance. We think we are Lord and master. It is very wrong. Patients are getting enlightened this way. In this world of internet, they read a lot. So if you deny them information, how can patients pay for investigations? Patients pay for CT, and we will not inform them and get them to know what their condition is. It is very wrong. We have to have a mind shift. As healthcare professionals, Because I've experienced it. If you empower your patients, the patient will see you as a magician because the patient is knowledgeable. So when you even set goals for the patient wants to attain or achieve those goals very fast. So education is important. We should have education. We should empower ourselves and also empower our patients. It will reduce hospital visits. The frequency of visits to our clinics will reduce. And that does not mean that we will not still have our money. We will still charge our patients appropriately if we have private clinics. But that should not even be the major focus of our care to our patients. We want them to be okay. And you know what? A patient that is empowered will tell another patient, and this snowballing thing comes in, and they begin to say, you see that Dr. Dada, if you go to his clinic, on the very first day, he will teach you. He will tell you what the whole thing is all about. Not just focusing on the interactions at the biological level or the organ or tissue level. He will tell you everything so that you'll be treated well. So we should change. When we have healthcare providers that are still holding on to the fact that don't let me disclose information, we should not do that in this era. It is unethical. Thank you, sir.
Thank you. I think there's a question on the chat box. Dr. Dada.
Thank you very much, sir. Thank you. Thank you very much. Just like I said, we are the Society for the Study of Pain, and this organization is a multidisciplinary organization, multi-professional, and we are an affiliate of the International Association for the Study of Pain, the IASP. And so I can say to you that we are one of the largest, if not the largest, multi-professional society in Nigeria, and I'm sure the IASP will be in the world as well. So if you want to join us, kindly get in touch with any of the ESCO members of the ESCO. I'm going to put my number on the chat, and I am sure my president too will put in his number. So if you can copy our numbers and then reach out to us at the end of the program. We want to encourage you. Membership is cheap. It's 10,000 a year. As new members, you will just pay also for the membership form, which is also 10,000 naira, and that is for a lifetime. So we encourage you to come join us and be a part of what we are doing.
Dr. Dada,
sir.
Dr. Dada, there are questions on the chat box.
Can I answer one of them?
Because it looks
please go ahead.
It looks as if you are trying to round up, but there are questions on the chat box.
Yes. Please go ahead.
Somebody will, her question is, can you kindly elaborate on the use of diet and the management of pain? I don't know when that comes up, but very soon there will be another webinar on this. So be on the lookout for it, and you learn from the nutritionist who was at the camp too.
So I'm sure you've received that message. Khadijat Shuaib. There were several professionals at the camp, physiotherapists, just like the presenter said, anesthetist, surgeon, nutritionist, neuroscience scientist, which are part of the facilitators. And so the nutritionist is also going to make a presentation based on the knowledge gained from the pain camp. So we are spoiled for choices. We've had Dr. Olateju, who is an anesthetist. He has shared, and if you want a copy of that presentation, just like I said, you can go ahead and check our YouTube page, the Society for the Study of Pain, Nigeria. You can check it. You will also be able to do that. Thank you very much, everyone.
Okay, there's another question.
Sorry, sir. I think there is a piece of information on the chat that the society, SSPN, should advocate that formation of pain clinic, running of pain clinic should be a requirement for accreditation of facilities. for
Okay,
different purposes. I think we can, it's an important take home. Thank you, Odole.
Dr. Lateju gave an opinion. I said plain clinic, good idea, but what of manpower, which is a major challenge? We can start pain clinic gradually, but should not be amongst the criteria for accreditation, at least for now. That's an opinion from Dr. Lateju. I just wanted to read it out. Noted. So that's the idea. Just like we said,
Yes.
well, it's a challenge.
Okay.
I missed that. I was locked out initially. So please help me, sir. I was locked out, so the chats are not showing again.
From Dr. Bonjubola, he said, the traditional temporal classification of pain include acute, subacute, and chronic categories, which some people are still using till present. However, I'm wondering if the subacute classification remains relevant in modern pain management.
Okay, thank you, sir. Yes, well, we know that we often classify pain under acute, subacute, and chronic, but in the RAT approach, pain is classified as either acute or chronic. But basically, if you classify pain under the subacute, that is pain that is more than 6 weeks for less than 3 months, you can do that maybe to prevent the pain to prevent chronicity of the pain. But based on the IASP classification using the RATs, the classifications are basically under these two subheadings, acute or chronic.
Okay, thank you.
Okay.
Yes, I hope Dr. Dada is not locked up again or locked out again.
No, I'm here. I just wanted to finish, but Mr. President,
before you
can take over,
Dr. Dada, okay. All right. Once again, we want to thank our immediate past president, Professor Aderonke Akinpelu, and other dignitaries that were here before. But I want to specifically mention that the main organizer, the chair for that first African Pain Camp, which is Dr. Andrew Amata, graced this presentation. So I'm so happy that he found time to be with us, although he's gone now, but he was here and waited till the end. And he was the convener, was the of that very serene environment. And as I've been advocated, we will try to see what we can do to try to create some sort of practical aspect of this experience here in Nigeria. But where to begin is the EPM, Essential Pain Management. They can get the website and repost it on our WhatsApp group platform for those who are members. These are supposed to be member benefits. So if you are not yet a member of the SSPN, it doesn't take much to belong. Membership, a member of the society. Dr. Akinpelu have said we cannot expect anything less from her HOD and mentee. So thank you for this wonderful presentation. This is not the last in the series. We still have 2 more presenters that will still talk to us about the experiences from the first African Pain Camp. And so I want to thank every one of you for attending this webinar today, and be on the lookout for the next one. Hopefully next month. Thank you very much, and do have a good night rest.